Right, let's get started. Thank you, folks. Thank you for joining us and good afternoon. Welcome. And thank you for joining us for session 5 of the Rural Research Collaborative Learning Network, so the RR-CLaN Research Education and Training Calendar. I'm Dr. Alex Stevens. I'm the Director of Research at Northern New South Wales Local Health District, and I belong to one of the member organisations of the RR-CLaN. Today, we're joined by a great team from Hunter New England Local Health District. We've got Doctors Reilly, Kingsland and Doherty. And together they will guide us through a session on implementation science to improve translation of evidence-based care. Next slide, please, Kathryn. To officially get us started, we acknowledge the traditional custodians of the lands upon which the lands and waters where we work and live. We acknowledge the traditional custodians of this living culture, their connection to country and their contribution to the life of this region. We pay our respects to the ancestors and elders of the region and to all Aboriginal people past, present and future, and any Aboriginal people who may be joining us today. So welcome. Next slide, please, Kathryn. Just a tiny bit of housekeeping. So given the large attendance, we'll probably sneak over about 100 attendees for this session today. We've muted your microphones, but we've left the chat option open. So if you have any questions, add them to the chat and we'll try to answer them throughout the seminar. If we do have a bit of time at the end of the seminar, we'll attempt to unmute your microphones and for the possibility of answering some live questions. Next slide, please, Kathryn. And so just a tiny bit more housekeeping. We're recording today's session for viewing at a later date. If you don't want to appear in the recording, just simply turn off your microphones. Next slide, please, Kathryn. So now it's my great pleasure to introduce you to today's presenters. We've got Doctors Reilly, Kingsland and Doherty. I'll start with Kathryn. So Dr. Kathryn Reilly is the Research Development Manager for Hunter New England Local Health District and been in that role or has over 10 years experience as health promotion research practitioner with Hunter New England Population Health. Dr. Reilly is involved in the planning, implementation and evaluation of preventive health services and research trials with a focus on implementation of policy and practice in community settings. More recently, Kathryn's research interests have expanded to include strategies to increase clinician and health service staff research capacity and engagement. Next on the list is Dr. Melanie Kingsland. So Dr. Melanie Kingsland is Program Manager by Hunter New England Population Health and a Research Fellow with the University of Newcastle. For the past 20 years, Melanie has worked on the development, implementation and evaluation of regional, state and national level prevention programs to improve the health of the community. Recently, Melanie's work has focused on the implementation of preventive care in routine clinical settings, particularly in relation to antenatal care addressing smoking, alcohol consumption, and gestational weight gain. Last but not least, Dr. Emma Doherty is a Research Fellow with Hunter New England Population Health and the University of Newcastle. Emma has 15 years experience working in partnership with health service to implement strategies that support the routine provision of preventive care to patients. Dr. Doherty's recent work as part of a PhD supported antenatal clinicians working in Hunter New England LHD Maternity Services to improve their provision of antenatal care addressing alcohol consumption. This initiative was found to be effective, increasing the proportion of women receiving recommended care and in turn reduce special occasion drinking during pregnancy. Now, without further ado, I hand over to the fantastic team who will guide you through today's presentation. Thanks, Kathryn.
Thank you, Alex, for that lovely warm welcome. I too firstly would like to acknowledge the traditional owners of the land we are all meeting on today and pay my respects to elders past, present and future, and acknowledge that the land we meet on today was and always will be Aboriginal land. And I'd also like to extend my acknowledgement to any Aboriginal staff members joining here today. So today I will start by giving a fairly high-level overview and introduction to implementation sites. Whilst this is still quite a new area of research, having said that, there is a fast-growing evidence base and published literature out there regarding implementation sites. And for many, the principles of implementation sites are not necessarily new. However, the importance and the more formalisation of implementation sites and implementation outcomes has developed more recently. I will then hand over to Mel and Emma, who will provide a case study and example of the role implementation sites has in translation of evidence-based practices in healthcare. As you are likely aware, it is widely acknowledged there is a gap between the identification of evidence-based practices and their consistent and widespread use in healthcare. There is consistent evidence of failure to translate research findings into practice globally. Studies have shown that 30 to 40% of patients don't get the treatments that have proven effectiveness, and nearly a quarter get care that is not needed or potentially harmful. There is a gap in what healthcare professionals know they need or want to do and what is sometimes achieved in day-to-day care. So what causes these implementation gaps? Why are health professionals not able to provide the level of care they want to for their patients? There are many reasons why this occurs, and I've listed just a few here. So there's the constantly evolving evidence base. Busy health professionals find it difficult to find the time or to stay up to date. The evidence is not always easy to interpret. Many perhaps have not been trained in how to appraise the evidence or how to make sense of it. Another challenge is the demands of increasing complex patient needs, an increasing ageing population with multi-morbidities, and the burden that can come with treatment, with treating these individuals. Added to that, healthcare systems are often complex and chaotic, and change can be difficult to instigate and manage. Another important factor on translation of evidence-based care is that health professionals are human beings. And as human beings, we develop habits and routines that help us get through our busy, complex days. We are not always good at assessing our performance, how well we are doing against what we intend to do. We often think that lack of skill or knowledge is actually the biggest driving factor for poor implementation of evidence-based practices. However, the biggest problem is often behaviour. There are many factors that can influence our behaviour, and as we all know, behaviour is one of the hardest things to change. So how can implementation science improve translation of evidence-based practices into routine healthcare? Firstly, let's look at the definition of implementation science. It is the scientific study of methods to promote the systematic uptake of research findings and evidence-based practice into routine practice. Whilst this concept is relatively new, there are other very similar concepts in research, such as formative research involving stakeholder engagement and conducting needs assessment. There are, however, newer concepts of implementation science. They are drawing attention to linking implementation outcomes to health outcomes, actively manipulating the implementation process through use of specific strategies, and looking at the impact of implementation on things like fidelity, so delivery of the evidence-based practice as it was intended, and then also looking at the impact on costs and eventually an overall sustainability of the evidence-based practice. So where implementation science fits in terms of research can be depicted in this simple diagram. To the left is the guideline, policy or practice or innovation that we want people to do in practice. The evidence shows that it improves health outcomes. Previously, we assumed that if you had an evidence-based practice or policy or innovation, then that would result in improved patient health outcomes. And there was a little effort or thought put into the implementation process, which is in the middle, or what was needed to get the evidence-based practice implemented successfully. So implementation research was really born out of the need to learn how to move evidence-based practices into routine practice and care delivery better. Implementation science is understanding how do you get people doing the evidence-based practice. So it's important to distinguish that there are essentially two components necessary to improve patient health outcomes. You need an effective treatment, practice, model of care, innovation, whatever that is, but you also need successful implementation of it by health professionals and services. So how this actually works is examining what works for whom and under what circumstances. It requires key actors to change behaviours and decisions. In a very simplified way, we need to identify who needs to do what differently, what factors determine whether or not they do it, which strategies can be effectively used to target those factors, and how can we robustly measure the outcome. So where to start? Well, there are over 60 implementation frameworks in the literature. You may have heard the saying that everyone likes a framework, but no one wants to use someone else's, and hence new ones are constantly created. You may find that for your particular research, you may benefit from using more than one framework or theory, and that is very often the case. I've just included a few examples in this slide, but obviously there are many, many more. Firstly, I've got there the Consolidated Framework for Implementation Research, or the CFIR, and it is one of the most well operationalised and widely used determinant frameworks, designed specifically to systematically assess potential determinants or factors that may impact implementation within local settings. And the CFIR is organised into 5 domains. So it looks at, firstly, innovation characteristics. So how complex is the innovation or the practice or the policy, and how strong is the evidence behind it? Secondly, it looks at outer setting, if there are any associated external policies, for example, or incentives. The inner setting, so what's happening at the organisational level, the organisational culture, and the extent perhaps to which stakeholders or leaders are engaged. It also looks at the characteristics of individuals involved, for example, an individual's self-efficacy in actually using an evidence-based practice or innovation. And then lastly, it looks at process. So what planning for implementation has occurred? Is there engagement with key stakeholders? So the CFIR can be used to assess context, and it can help guide decisions about the types of strategies that may be appropriate to match the needs of the local context. The second one I've got there is the Expert Recommendations for Implementing Change, or ERIC tool. And this was developed to support systematic reporting of implementation strategies. There was a lot of variance in how researchers were reporting the types of strategies they were using to facilitate implementation. So this tool actually has a compilation of 73 discrete implementation strategies that either involve an action or a process, a method of delivery. And these provide a great, I guess, list or tool to go to in terms of looking at potential implementation strategies. The Theoretical Domains Framework is another common one you'll see in the literature, and it simplifies 33 theories and 128 constructs, which may explain behavioural change, and it simplifies them into 14 key domains. And these domains are individual level factors such as knowledge and skills, social factors, and environment and resource factors. So they therefore prompt the consideration of a real wide range of influences on behaviour. The last one I've got there is the Compatibility, Opportunity, Motivation Model of Behaviour, or the COM-B model. And this almost combines or reduces the TDF into 3 key domains that interact to predict behaviour. And that includes people's capability, their motivation, and their opportunity for the behaviour. So these are just a few examples of frameworks in the literature that can help you to begin to think about designing an implementation intervention. A key part of implementation science is that active manipulation of the implementation process, and this is achieved through the use of implementation strategies. So implementation strategies are methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. Well, they're the real how of implementation. How do we get people to implement? You may choose to use one implementation strategy, or you may combine several together to target different barriers and enablers to implementation. It is important to understand that different strategies are likely to be effective in different contexts, and that strategies should be tailored to the local context. So how do you select which implementation strategies are best? Well, firstly, you need to understand the determinants or the factors of implementation in the local context. This will include identifying barriers and enablers to implementation. Then you need to identify what methods could address these and develop strategies that influence these. For example, you may identify that healthcare staff are not confident in a particular evidence-based practice and lack the confidence to carry it out. Therefore, you would look for strategies that enable individuals to build their confidence. And just some examples might be through training, through audit and feedback, having a champion in the service who can support staff. So the ERIC tool that I mentioned earlier does provide an extensive list of behaviour change approaches and methods of delivery that may be included as implementation strategies, and there are just a few examples on the screen there. In order to determine the effectiveness of these intervention strategies, like any research, it is important to evaluate. Implementation outcomes are kind of implementation proxies that help us understand the effects of implementation strategies. So that is whether the evidence-based practices are being implemented, and they act as intermediary outcomes for system improvements and clinical outcomes. The implementation outcomes listed here on the left are commonly used terms proposed in the Implementation Outcomes Taxonomy, which was developed by Proctor and colleagues in 2011. And these outcomes include 8 conceptually distinct but interrelated implementation outcomes. So acceptability is the perception among implementation stakeholders that the given, practice or treatment or innovation is agreeable or satisfactory for their service. Adoption is the initial intention or decision or action to actually take on or implement the innovation or evidence-based practice. Appropriateness is the perceived fit or relevance in a particular setting or for a particular provider or consumer. Feasibility is the extent to which a new innovation or evidence-based practice can be successfully used in a particular setting. Penetration is the integration of that practice within the service setting and its subsystems. Sustainability, the extent at which that the implemented evidence-based practice is maintained within that service ongoing. The costs relate to the costs of the implementation effort. And fidelity is the degree to which an intervention was implemented as it was intended. And some would argue that is perhaps potentially the most important implementation outcome. So you'll see in that diagram that there is a difference between the implementation outcomes are quite separate to the system or the service outcomes and clinical or patient outcomes. So there are numerous ways to measure these implementation outcomes, and I've included just a very handful of examples here. Often surveys, questionnaires, or interviews are appropriate for a lot of those outcomes, but you will find that administrative data is often available that can help with evaluation. So if you're wanting to measure things quantitatively, then here are a couple of good places to start to look for measures. The first one I've got there is the Implementation Outcome Repository. So this is a free online resource to identify quantitative implementation outcome measures. It lists available resources for each of those constructs that were in the previous slide. The second one is the SERC Instrument Repository. That's the Society for Implementation Research Collaboration Instrument Repository. You do need a membership to access this, so I think there is perhaps a fee associated with that. It has a review of instruments that has been guided by the CIFA, which was one of the frameworks that I mentioned previously. And then there are numerous systematic reviews in the literature that look at, consolidating implementation outcomes and measures. So if you're perhaps wondering how or where to start in terms of incorporating implementation science into your research, then you may consider the following. So firstly, simply applying some implementation science by incorporating the use of implementation strategies based on context into your intervention planning and delivery. You may want to integrate implementation science approaches through the delivery of strategies and then the measurement of implementation outcomes. There is also what we call hybrid effectiveness implementation trials that include implementation outcomes. These hybrid trials focus on both effectiveness and implementation outcomes. And there's a hybrid effectiveness implementation typology where there are 3 different types. So the first type, which has the primary aim of effectiveness and secondary aim is implementation, tests effects of a clinical intervention or relevant outcomes while also observing and gathering information on implementation. Type 2 is the equal kind of testing of both clinical and implementation interventions or strategies. And type 3 has a primary aim on implementation this time, but then also gathers information on the clinical outcomes or patient outcomes. And it's proposed that the use of these hybrid designs could actually speed the translation of research findings into routine practice, as testing effectiveness whilst also generating knowledge regarding implementation is obviously going to be beneficial and speed up the translation process. Another application, I guess, to consider is the inclusion of implementation approaches in quality improvement projects. You know, quality improvement projects, whilst not research, often are involving a new model of care or a new practice. And so it does often require behaviour change by healthcare professionals. And so I would think, or I definitely would consider trying to incorporate some of these implementation science approaches within quality improvement projects as well. So in summary, a very broad approach to using implementation science to help the translation of evidence-based practices is by asking the following questions. Who needs to do what differently? What barriers and enablers need to be factored in and addressed? What intervention components, for example, strategies, can address these barriers and enablers? And how can we measure the change in implementation and if the intervention strategies have worked? There are a number of resources available if you want further information regarding implementation science. There is the National Centre of Implementation Science, which has been founded by actually quite a number of Hunter New England researchers and others across the nation. And they have lots of resources on their website and webinars and so on. There's also Sydney Health Partners Implementation Science Academy. They have resources and they have workshops and a number of different activities across the year. And there is a dedicated implementation science journal where you'll find a plethora of literature and information. So they're just a few thoughts in terms of where to go to for more information. I have given you a fairly high-level overview of implementation science. It is very much an evolving science and expanding beyond, I guess, the traditional approaches of implementation science and looking at adaptation and how do we optimize implementation intervention strategies. So it's a constantly kind of growing field, and it's an exciting field because it actually is, I think, something that is very important and can really make a difference around translating the evidence that's generated into actual practice. So that kind of winds things up for my portion of this presentation. So I will stop sharing if you like, Melanie, and I will hand over to you.
Thanks, Kathryn. Okay, how is that looking? Can you see that?
That's
okay,
come
thank
through
you.
well.
Great. Okay, so that was a really great background that Kathryn has provided, and hopefully now what Emma and I can do is to show you how we've practically applied some of those theories and frameworks and processes to some work that we've been doing over about the last 6 years in Hunter New England. And what we're presenting today is really a big partnership project between the population health team that we are and Maternity Services, as well as a lot of other partners. And you'll see that on one of the slides. Okay, so before I commence, I did want to also acknowledge that I'm meeting today from the land of the Awabakal people, and to pay my respects to elders past and present, and to acknowledge any Aboriginal people online today. So in terms of preventive health in pregnancy, what we're talking about are primarily 4 key risk behaviours that kind of lead to good outcomes for mothers and babies. And there are established guidelines that indicate what can lead to a healthy pregnancy in terms of not smoking, not consuming alcohol, consuming a healthy diet, and maintaining good sort of physical activity throughout pregnancy. However, we know that for many different reasons, that isn't always, those guidelines aren't met. And for many people who are pregnant in Australia, those guidelines aren't met to a great extent. So here are just some figures in terms of the proportion of pregnant women throughout Australia who aren't meeting those guidelines. However, antenatal care throughout Australia provides us really great opportunity to support pregnant women to meet those guidelines and at least make some progress towards meeting them. So, and we have some clear guidance established through a number of documents, including the clinical practice guidelines for pregnancy care, that outline that there are 3 sort of main components of care that clinicians can undertake when they see women routinely as part of their antenatal care to provide that support. So, and they are across all of those health risks that I mentioned. So smoking, alcohol, physical activity, nutrition, and also kind of weight gain. That there is a recommendation that all women routinely are asked or assessed for those health risk behaviours, that advice is provided, and that advice is about what the recommendation is, but also of the benefits of trying to meet that recommendation. And that thirdly, that help is provided if extra support might be needed, such as referral to support services such as the Quit Line or Get Healthy in Pregnancy, and other supports that might be required, such as with smoking, there may be the need for nicotine replacement therapy. So they are the key steps that are outlined in clinical guidance for this area. However, we also know from a number of research studies that less than 10% of women have been receiving that recommended care for those health risks in pregnancy. And therein lies an implementation challenge and some questions for us. So we've been working across the last 6 years to understand really strict and across kind of pregnancy for different women. What are the barriers that clinicians face in providing recommended care? And then what are the potential solutions or implementation strategies that could help improve that care? And you might recognise that they're kind of the stages that Kathryn mentioned that we need to move through in understanding kind of implementation challenges and solutions. So these are the things that we've tried to understand. And what I'll do now is I'll break down those 3 questions in terms of how we collected the data to try and understand and answer that question and what we found. So in terms of our first question about current implementation, we very early discovered an excellent method of finding out what was being delivered to women in their antenatal appointments, and that was to call women up after those appointments and ask them. So we have been conducting for about the last 6 years telephone surveys with pregnant women who have just recently attended an antenatal appointment in our district, and we have asked them to report on their receipt of those 3 care elements, so assessment, advice and help for smoking, alcohol consumption, weight gain, physical activity and healthy diet. And as I said, that has been a very successful method. We have spoken to around 20,000 women or more over that time who have given up some of their time to help us understand what's actually been implemented in their appointments. We do actually also offer online survey completion, but just to note that that is not completed anywhere near as well as the telephone surveys are. So that is definitely still our preferred method at this stage. And so this is what we found. So we have found that it is very important to ask very specific questions. So as you can see, there is really different levels of reported care that we have found out between the 3 health risks. So smoking, alcohol, and weight gain. And weight gain actually combines physical activity and nutrition care in that. And also a real difference between all of those care elements. So if we were to have combined all of that together and just asked women about smoking care, we would have lost the benefit of seeing the detail that this provided in terms of letting us know that actually women are receiving, well, a large proportion of women, almost all women are receiving assessment for smoking. However, only 38% of women are receiving extra help that they need to support that care. And as you can see, it also really highlighted that gestational weight gain care wasn't received by most women. Actually, really less than 30% of all women reported any of those elements. So what this did is it really helped us identify where there was a need to undertake that next step. So where there was a need to identify what the barriers were, and also where there was a need to obviously improve care. So it gave us some targets to work on. Also, drilling down into the data a little bit more, we also understood that even though the guidelines actually recommended that care was delivered to all women routinely, irrespective of any other factors, we found that care was being delivered inconsistently to all women, and that it was being delivered actually on the basis of some factors that were very broad, such as age, whether it was first pregnancy or not, BMI at the start of pregnancy, rurality, education level, and identifying as Aboriginal. So there were things that we had to really understand about what was happening with that care in order to develop some solutions. Our second question, identifying barriers to implementation. So we then turn to survey the clinicians about this. So to understand why it was that they weren't providing this kind of best practice care that had been outlined. And we did that through online and paper surveys of antenatal care providers, so midwives, Aboriginal health workers, doctors, anyone that provided routine antenatal care. We did those through facilitated kind of surveys. So we actually went into a meeting, a team meeting, or a huddle, or maybe another training session, had those surveys completed on site. And in terms of the content of those surveys, we asked all the clinicians to report on the barriers to routinely providing recommended care for all of those health risks. And we framed the survey in terms of one of those frameworks that Kathryn mentioned, the theoretical domains framework. And really that was so that we didn't miss anything. So I think what's really great about these frameworks is that it takes clinicians through all the different types of things that may be influencing their behaviour and their care, and gets them to think about all of those things. Because people, if you just ask them about barriers, often go straight to say time, or I don't have the capacity or something to do this. They don't think about all those other things that might actually be impeding their practice. So that was great to be able to kind of get everyone to look at a broad range of issues. We also use something called a best worst scaling method. And all I suppose you need to know about that is that enabled us to prioritize those barriers. So often when you ask people about barriers and you use a framework, you get lots of barriers. So we use this method so that we could actually pull out which of those barriers were the most important to address, so that if we had limited resources, we could just focus on addressing some of those. So this is what we found, and I've just picked out a few things to kind of demonstrate what we were finding. So some of the barriers were prevailing across advice and help, and across all those health risks, whether it was alcohol consumption or tobacco, etc. And one of those things was belief about consequences. So this is the term used in the TDF, or the theoretical domains framework. But what that was referring to was what you can see here in the grey kind of bubbles, that clinicians are saying that other things take a higher priority in antenatal care, that addressing preventive health risks is not as important relative to those other things. So it was not seen as consequential to not do. So yes, that was mapped to this kind of belief about the consequences of it, was really at the heart of one of those barriers. And also that was reflected in concerns that clinicians had about women not wanting to address these health risks and potentially feeling uncomfortable in their antenatal appointments. So that was preventing those health risks from being addressed. So that's something that prevailed across everything that we were looking at. Another thing that prevailed as a key barrier was environmental context and resources. And that was in respect to clinicians identifying lack of time within the structure of their antenatal appointments, and also limited access to resources such as referral documents, and also the actual referral service being in existence in their community. So that again prevailed across all of the health risks. We also found that some barriers were quite specific to either one care element or one of the health risks. And so I suppose highlighting that it is essential that you kind of go through all those different elements that you're trying to improve, because there might be a barrier that sits on just one of them. So for instance, memory came out as a key barrier for assessing alcohol consumption at follow-up appointments. And that was identified as something that therefore needed to be addressed. We also found that optimism, or lack of optimism, pessimism, was a barrier in terms of referral to the quit line. So clinicians identified that they believed that women would not take up the quit line, so they weren't actually referring to it. So they had this belief that women wouldn't actually go through with the quit line referral, so I won't bother referring on. So that was an important thing for us to identify as a barrier that was holding back care. And our third question, what are the implementation strategies that might be needed to address these barriers? So we did that through a development process that links some of those things that Kathryn was talking about. So we wanted to identify some behaviour change techniques that could address these barriers. So they're basically the active ingredients that would actually address those barriers and try and produce some change in care. And then we wanted to also identify some implementation strategies. So the kind of delivery vehicles that we would put those active ingredients in order to deliver them to clinicians. And they were chosen based on definitions in the ERIC and EPOC taxonomies. So the ERIC taxonomy, Kathryn mentioned before. So they're basically just lists of strategies that you can choose from. So here are some examples of how we went through that whole process. So I'm just going to show you two different examples to show you how we undertook that process, but we did it for many things. So the first barrier that clinicians identified that I will provide an example for is I forget to advise on physical activity in antenatal appointments. So that was mapped to the theoretical domains framework of memory, again, attention and decision making, but particularly about memory. And the behaviour change technique that can be mapped to that is provision of prompts and cues. And how that could actually be delivered to a clinician as a strategy is through some reminders that could be put at their point of care when they're in that busy antenatal appointment to actually prompt the provision of advice on physical activity in that appointment. Another barrier that clinicians reported was I don't have the skills to offer NRT to women. And so that was mapped to the theoretical domains framework of skills. That's an easy one. And the behaviour change techniques that were mapped to that were providing instruction on how to perform the behaviour and providing behavioural practice or rehearsal opportunities to actually refine those skills. And how that was delivered to clinicians on a very practical level was through conducting educational meetings or training sessions, and that content of that being about the how, so the actual instruction on how to provide NRT, and to include some role plays and some real practical demonstrations on that to build those skills that were required. So as you can see, these two examples are really different. The strategies are different. If we had just provided training on physical activity, that wouldn't have addressed the key barrier, which was memory. And if we had done the flip and provided a prompt for clinicians about NRT, they still may not have been able to provide it because the barrier was about skill. So we have to make sure that we're quite clear on what the barrier is and we're addressing that by an appropriate implementation strategy. So what we have been doing now is that we have, over the course of those kind of 6 years, put together those strategies into a number of trials. So we have been trialing whether those strategies, which theory suggests actually should work, actually do work in reality if we're delivering them to clinicians. And so we have conducted, in the process of conducting 3 step wedge trials. Emma will go into in depth about one of those trials in a minute. There's 2 protocols just listed on the bottom of this slide where you can find out some more information. But basically those 3 trials are step wedge trials. So we're delivering the package of implementation support to one site, then moving on to another and to another. So we're providing step sequential kind of rollout of our strategies, and the settings that we've been providing that support into the clinicians are maternity services across Newcastle, Tamworth, Gunnedah, Corindi and Taree. So different types of settings to see whether these strategies work for different types of clinicians in different types of contexts. So before I pass on to Emma to tell you about one of those trials in a bit more depth, I just wanted to touch on the fact that for us, these implementation trials have been a team effort. They are definitely, you definitely need to gather around you partners and investigators from all different stakeholder groups to make these trials work. So this is an example of the trial that Emma is actually going to discuss, where we had health service level partners that were absolutely essential for the co-production of the actual intervention and the implementation strategies, and really the support for the trial happening on the ground. We had policy level partners that were able to enable changes to be made to statewide clinical systems and to translate findings statewide. We also engaged the National Advocacy Organisation in this space, FAIR, who was able to then translate some of those findings to national campaigns, but also to consumer groups. And then we had researchers on board, implementation science specialists, methods people, and clinical researchers who could provide that scientific expertise and rigour to what we were doing and help us build the evidence base through publication as well. So I'll hand over to Emma now, who will take you through one of those trials that I mentioned.
I'll just share my screen. Can everybody see that?
Yes.
Yep.
Brilliant.
Awesome. So I'll talk now to the trial that looked at improving care around alcohol consumption. So this is a trial that we ran from about 2017 to mid-2020. So this trial is complete. So this trial was conducted, as Mel mentioned, as a randomised step wedge controlled trial. And there's a figure of the trial design down there at the bottom of the slide. The outcomes of this trial that we were interested in were receipt of guideline recommended care. So those 3 steps Mel mentioned before, assessment, advice and help, to women in their routine antenatal appointments. So these outcomes were measured for the duration of the trial. So this trial went for 35 months via surveys with weekly random samples of women post an appointment with the maternity services that were participating in the trial. And as you can see by the little figure down there, there's a period of baseline data collection where kind of all 3 sectors that comprised of those maternity services didn't receive any kind of implementation support, and we were just collecting data about what was happening in the baseline period. Those 3 sectors then moved into receiving a 7-month implementation package. So sector 1 received it first. It finished before we then provided it to sector 2 and then sector 3. And then there's a period where all those services are then in a follow-up data collection period. So the effect is determined by comparing what women told us about their care provision in the baseline period versus those follow-up periods for the three sectors there combined. So step wedge trials are a really useful study design to use in implementation trials because they evaluate the implementation at a service level, which is quite often the level that we're working at in implementation, like we're putting prompts in systems that say all clinicians are exposed to. It's a bit more of an equitable approach in that all services eventually receive the implementation strategies and the potential benefits from those. It just demonstrates feasibility in a real world setting. And from a scientific point of view as well, it's robust. It provides the same level of evidence as, say, a cluster randomised controlled trial would. So antenatal clinical guidelines at the national level are actually quite broad in what they recommend. So they recommend these 3 steps around assessment, advice and help, but don't really provide any further detail about what the care pathway is on the ground. So kind of our first step was detailing each of those 3 components of care for the maternity services and also looking at what visit types they were to be delivered in. So this was the care pathway that was delivered as part of the trial. So all women at their initial visit, a visit around 28 weeks and 36 weeks gestation, were to receive an assessment of their alcohol consumption via the Audit C, advice that covered that it's recommended not to consume alcohol and a discussion of the risks. And for those women who needed some further help to stop consuming alcohol in pregnancy, it provided pathways for that. So just to mention that when developing these care pathways, it's important to ensure that they're evidence-based, they fit with the practice of the services that you're working with, and that they're localised. So these are some of the implementation strategies that were put in place over that 7-month period with maternity services. I won't go into them into too much detail given time, but as you can see, there are really quite practical type strategies that we came up with. So there was leadership support, there was a series of online and face-to-face training, clinical guidelines that really highlighted those localised pathways for clinicians, a local champion on the ground providing support, performance measures, and electronic prompts and hard copy prompts that were integrated into the medical record system used by maternity services. So these strategies were developed in response to the barriers that we had identified through the clinicians surveys that Mel mentioned. We went through a mapping process like Mel mentioned as well, using theoretical frameworks and evidence. Within these strategies, there was consideration to priority populations, and for us, especially, that was consideration about supporting clinicians to provide care to Aboriginal women. And these strategies were developed in partnership with maternity services to make sure they were feasible for the context and they were embedded into routine systems and practices and processes. So the trial outcomes, which were around care receipt, as I mentioned, are on the screen. So over the 35-month period, we conducted surveys with about 5,500 women. So this is the results. So the baseline period is in that light purple and the follow-up period is in the dark purple there. And as you can see, there were significant improvements in receipt of all those care elements due to the implementation. So the odds of receiving care at follow-up compared to baseline ranged from 1.7 for advice around potential risks up to about 2.6 for assessment using the Audit C and advice around it's safest not to consume. So these are the overall results, but we also looked at whether there were any differences between the two different antenatal visit types, and found that there was. Subsequent visits had higher odds and significance due to starting from a much smaller baseline. We also conducted some subgroup analyses of these trial outcomes and found that there were actually similar effects between different subgroups of women. So like some of those characteristics that Mel mentioned before, where there were differences prior to implementation. So by women's age, their Aboriginal origin, their education level, and by the types and locations of services that were involved in the trial. So there were similar effects between midwifery and medical and Aboriginal maternal infant health services, as well as those services based in urban locations versus regional rural locations. So after the implementation was delivered in each of the sector, we conducted surveys of women and clinicians asking about some of those implementation outcomes that Kathryn mentioned. So in terms of the care pathway that was implemented, women, like almost 100% of women, rated that care pathway as acceptable to receive in their antenatal visits. And clinicians scored it a mean score of 4 out of 5, so quite high. In terms of the implementation strategies that were delivered, that they achieved quite good reach. So almost clinicians reported that they received almost 7 out of those 8 strategies. And they also rated the acceptability and appropriateness of those strategies quite high as 4 out of 5. We also asked about the individual strategies so we could determine whether there were any differences. So the implementation strategy with the lowest reach was performance measures, and the one with the highest reach was electronic prompts. And the implementation strategy with the lowest acceptability was leadership, and the highest was the local champion that was put in place. Over the trial too, we also kept logs of every single cost associated with implementing this intervention with the services so that we could determine the overall cost in implementing it and also how much it costs per % increase in full guideline care delivery, which is that ICR number down the bottom. So this implementation intervention cost over $300,000, with 70% of that coming from labour cost, which was mostly the wage of the clinical midwife educator acting as the champion. And there was 65% of the cost related to delivering training. And as Kathryn mentioned, that these implementation outcomes are key intermediate outcomes to collect. They aid interpretation of your main trial outcomes. They provide information on improving current and also future implementation processes. And they also provide really useful information for decision makers and services for further rollout of these types of implementation strategies. And I would just reiterate what Kathryn said around looking at the Proctor taxonomy. And then just lastly, we also looked at whether this implementation trial led to improved outcomes for the woman. And we found that, yeah, at the end of the trial, there was a significant reduction in women reporting special occasion drinking during pregnancy. So at baseline, almost 12% of women were reporting alcohol consumption, and at follow-up, this was down to 8% consumption. And that's where I'll leave it. Thank you.
Thank you very much, Melanie, Emma, and Kathryn for that fantastic presentation, and Kathryn for providing that high-level overview of implementation science, and Melanie and Emma for that excellent sort of practical application of implementation science in practice. Really fantastic. We do have a tiny bit of time for questions, and what I'm going to try to do is just unmute people's microphones in case there are any live questions. Allow mic for attendees. And then while I wait for any questions, what I might do is just share my screen to give a plug for the next RR-CLaN session. Sorry, just bear with me. So hopefully that's sharing now. Do have one question up, but just the plug for the next session will be next Wednesday, next month, sorry, on Wednesday, the 5th of July. And this will be tips and tricks for navigating research ethics and governance processes. So hopefully that'll be handy for people that want to submit their ethics applications. We do have one question from someone, which I'm trying to get to. Jessica, the floor is yours.
Hi, thanks. That was a really interesting presentation, and I've seen stepped wedge used in the Northern Territory, so it was nice to see it in a really different setting. Just a question about the final slide on the outcome for, you know, the behaviour change in women, which, you know, surely is also part of the point. I'm just wondering if you, and it might be in your papers, so apologies, but is there any possibility that increased explanation of risks about alcohol use in pregnancy to the women then turned into reduced reporting of alcohol use, you know, because they were increasingly aware that it wasn't a good idea? Do you think that could have confounded the result, or you know, I don't know if you can measure that, or what you thought about that contribution to the result?
Yes, so in the surveys, we were just asking women. So the surveys were of just women. We asked them about their behaviour and then the care they received after the appointment. So those surveys, it wasn't the same group of women that we followed through. It was just a random selection of women that occurred at baseline and follow-up. So it's what they were kind of potentially exposed to was the same care provision in both those periods.
Great, thanks for explaining that.
Fantastic. Are there any other questions? Doesn't look like it. I would encourage attendees, if you can, spare 5 minutes to complete the evaluation survey so we know how we're going, with the view of potentially increasing the content we can provide through the research, education and training calendar next year. So if there are no other questions, I once again want to thank Kathryn, Emma and Melanie for the fantastic presentation. Please join us again next month. We've got another session for you guys on research ethics and governance. Otherwise, I'll draw today's session to a close. Thank you very much for attending, and hopefully we'll see you again. Thanks, everyone. Bye-bye.
Thanks, Alex. Bye.